is being recorded. Any objections, you may disconnect at this time. Now I'd like to turn over the meeting to Carl Yonder. You may begin.
Thank you for joining us for the Bureau of Health Workforce Grand Rounds webinar series, Telehealth Training Models for the Health Workforce. Today's presentation can be downloaded by clicking on the file located in the bottom right-hand corner of your screen. When the file is highlighted, click the Download Files button, and you can then save the file in a location of your choice. At the conclusion of today's presentation, there will be an opportunity to ask questions online and over the phone. To ask a question online, you'll just type in the question in the chat pod located underneath the bottom of today's presentation, and the operator will go over instructions on how to queue up to ask questions over the phone. Thank you again for joining us today. We hope that you find the webinar incredibly helpful. I'll now turn the presentation over to Michelle Goodman.
Hi, and thank you. Good afternoon and good morning to everybody. Thank you all for joining us at today's Grand Rounds presentation. Our objectives for this webinar are to explore with you some of the opportunities to optimize telehealth technology, identify telehealth strategies and models in hard-to-reach populations, including both rural and urban communities, and to highlight successful telehealth training modules. Telehealth is an important tool to help address some of the persistent clinical shortages in rural, frontier, and other underserved communities. For many of our workforce grantees, we see telehealth not only as a way to enhance clinical services, but also as a form of distance learning, providing a link to trainings for new clinicians and supporting the continued education and training of clinicians that have been practicing for some time. I wanted to take a couple of minutes at the beginning of this presentation to give you a very high-level overview of the efforts of the HRSA telehealth work group over the last year before I turn the webinar over to our featured presenters. Over the last 30 years, HRSA has been a leader in the field of telehealth and is home to the Office of the Advancement of Telehealth, or OAT, which you will hear about more from one of our presenters. In 2017, through the leadership of our administrator, Dr. Segunas, and the HRSA Telehealth Work Group was formed with representation from all bureaus and offices in HRSA. The purpose of the group, led by Dr. Segunas and the Federal Office of Rural Health Policy, is to coordinate and advance telehealth activities across HRSA. The work group has three broad strategic goals: increase the number of individuals and communities in HRSA's target populations that receive services and or support using telehealth technology, increase HRSA's visibility and leadership in the field of telehealth, and to encourage the use of telehealth technologies to support department and agency priority areas, such as the opioid epidemic. Through this work group, we inventoried all of our programs here at HRSA and know that 8 of HRSA's bureaus and offices have awards with a telehealth component or are engaged in telehealth activities. All 50 states and 8 federal districts, territories have awards that have a telehealth component, and activities include supporting distance learning, workforce development, telehealth delivery, infrastructure, and research. Some of the other activities carried out by the work group last year included strengthening the connection between the telehealth resource centers to the HRSA's regional offices, as well as with the National Health Service Corps participants and sites, initiated a project officer training series on telehealth to begin to link project officers and programs across HRSA that have grantees using telehealth. We launched a telehealth webinar series for HRSA grantees and stakeholders, highlighting successful projects and best practices with presentations by HRSA grantees. Some of the topics covered at those webinars included highlighting the use of a substance use warm line, which provided consultation on substance use evaluation and management for primary care clinicians, and lessons learned through HRSA's school-based telehealth network. In 2019, we are continuing to maintain HRSA's leadership in the field of telehealth and will continue to encourage our grantees to use telehealth technologies to support departmental and agency priorities and increase the number of individuals and communities in HRSA's target population served by telehealth. We are also focusing much of our work this year on improving our telehealth data collection efforts across the agency. We are currently looking at what every bureau and office is doing around telehealth measures and data collection, creating an inventory of all the measures we are using in order to better align and coordinate across the agency and to build the evidence base for telehealth for HRSA programs. Well, that was a very quick summary of the efforts of the HRSA Telehealth Work Group, and so now I want to turn our attention to the main event for this webinar. Our panel of speakers include Carlos Mena, who will provide the federal perspective on telehealth and the work of the Office for the Advancement of Telehealth, Dr. Helene Silverblatt and Dr. Van Roper from the University of New Mexico, who will be presenting on the primary care AHEC teleecho clinic model. And concluding our session, we will hear from Dr. Raul Sharma and Dr. Peter Greenwald, who will provide us with an overview of the work that they are doing at New York Presbyterian Weill Cornell Medical, training clinicians to use telehealth. So without further delay, let us begin with our first presentation. A quick bio on Carlos. Carlos Mena currently serves as the program coordinator for the School-Based Telehealth Network Grant Program for the Office for the Advancement of Telehealth at the Federal Office of Rural Health Policy. In this capacity, he has extensive knowledge in telehealth and managing grant programs. Carlos will be starting us off providing the federal perspective on HRSA's role in telehealth and more specifically the Federal Office of Rural Health Policy's work in telehealth. The floor is yours, Carlos.
Thanks a lot, Michelle, for the introductions, and welcome all to the webinar. I'm Carlos Mena, and I'll be providing you all in the audience a brief overview of HRSA, one of its offices called the Federal Office of Rural Health Policy, which Michelle just mentioned, or better known as FORP under that acronym, and more specifically the division within FORP that I work in called the Office for the Advancement of Telehealth. So just a bit of a background on HRSA. We currently support more than 90 programs that provide health care to people who are geographically isolated, economically or medically challenged. This is done through grants and cooperative agreements to more than 3,000 awardees, including not-for-profit organizations, a variety of healthcare settings, academic centers, state, local, and tribal governments. And as a result of such programs, tens of millions of people are served, including HIV/AIDS patients, pregnant women, mothers and their families, and those otherwise unable to access quality health care. One of HRSA's offices is the Federal Office of Rural Health Policy, which was created in 1987 to address the problems for rural hospitals that arose from the implementation of the prospective payment system. FORP serves as a voice for rural within the Department of Health and Human Services and administers grant programs, makes policy recommendations, and facilitates evidence-based research on rural health. Most of FORP's grant programs are authorized within Section 711 of the Social Security Act, with the Office for the Advancement of Telehealth joining in 2010, and in FY 2018, Congress appropriated additional funds to support treatment for and prevention of substance use disorder, including opioid use disorder in rural counties at the highest risk for substance use disorder. FORP supports more than 300 rural communities via grants to test out ideas on improving access to services, coordination of care models, building the evidence base on effective ways to support rural populations. Many of the lessons learned from those projects can be found on the Rural Health Information Hub via the website ruralhealthinfo.org. And this website provides a wealth of information, opportunities, and acts as a national clearinghouse on rural health issues. One can simply Google Rural Community Health Gateway to find a number of models that work, toolkits, and several timely resources of benefit. So within the Office for the Advancement of Telehealth, our priority mission is to promote the use of telehealth technologies for clinical service delivery, peer-to-peer education, and health information services. One important mention here is that our office promotes telehealth as a tool for conducting the types of communications shown on this slide. OATS grant programs work on contributing to the evidence base and coordinating grantee activities towards these common goals. And for example, our telehealth resource centers, which I'll share a slide about shortly, provide technical assistance to healthcare organizations, healthcare networks, and healthcare providers in the implementation of cost-effective telehealth programs to serve rural and medically underserved areas and populations. In addition, we also support the evidence-based Telebehavioral Health Network Grant Program, designed to support broad telehealth networks to increase access to behavioral health care services in rural and frontier communities, and to conduct evaluations of those efforts to establish an evidence base for assessing the effectiveness of telebehavioral health care for patients, providers, and payers. We also support a rural telehealth research center that's led by the University of Iowa to increase the amount of publicly available, high-quality, impartial, clinically informed, and policy-relevant telehealth-related research. As folks in the audience may be aware, telehealth has seen tremendous growth in the last 5 years, particularly within the private sector, as price of telehealth technology and equipment has steadily declined. And across HRSA's bureaus and office, we discovered that for fiscal year 2018, there are currently over 1,000 HRSA awards that include a telehealth component. Most of those 1,000 recipients are supported by HRSA's Bureau of Primary Health Care, and more than 500 health centers use telehealth to provide primary care and specialty care, mental health services, and manage patients with chronic conditions. Within the Office of Advancement Telehealth, I'm the program coordinator of the Telehealth Network Grant Program, and it was authorized in 2002 under Section 330 of the Healthcare Safety Net Amendments, with the objective of supporting established networks to help increase delivery of badly needed services for rural populations. Since the program's inception, we've observed telehealth evolve to a point where providers and patients have become accustomed to the utilization of technologies for services, and the range of services and providers addressable by telehealth has also increased. For example, the static cost of broadband and technology has decreased, and so the quality and capability of the technology is increasing exponentially. But the cost of broadband and technology and the need to update technology remains a barrier to new entrants. In addition, the emphasis to utilize telehealth to train healthcare providers has led to many Project Echo models now becoming an important aspect of remote practice. All in all, experience from the Telehealth Network grants is generally expected to have broad application by identifying best practice models that can then be adopted at state or local levels for the ongoing care of patients. I apologize if the infographic does not clearly show on your end, but wanted to share a key result and note that through the Telehealth Network Grant Program, we capture on an annual basis the patient travel miles saved between the location of the patient's local primary care provider and distance to the nearest specialist. Earlier this year, HRSA published its year in review for 2018 and highlighted the program for saving nearly 1.6 million miles of patient travel across the cohort of recipients. When multiplied by the mileage reimbursement rate of 55 cents, that equates to $880,000 in savings for that fiscal year alone. It's a simple example that demonstrates telehealth benefits in saving patients time and money, but a lot more work is being done to build the evidence base on telehealth quality and effectiveness of care compared to a face-to-face visit. The program is now supporting its 7th cohort, whose project period began on September 1st, 2016, and for the first time, its focus is solely targeting children populations within rural schools located in high-poverty areas across the country. The basis for this new focus came out of the HHS Office of the Assistant Secretary for Planning and Evaluation report that was published in 2015, entitled Environmental Scan of Programs and Policies Addressing Health Disparities Among Rural Children in Poverty. The report highlighted 5 priority clinical services that our cohort of 21 recipients are offering via telehealth. Those 5 services, as shown on the slide, include asthma, diabetes, childhood obesity, behavioral health, and oral health. For the last 2+ years, we've seen that telehealth in schools has many benefits that we're working to build the evidence base on. And for example, telehealth so far has demonstrated a decrease in absenteeism. It's a safe, convenient place with trusted personnel and interest in the child's well-being. It also has great potential to decrease stigma. Kids also accommodate well to technology, and telehealth decreases patients' time away from work, and it provides many families a point of entry into health and mental care systems. So the map on your left was developed by the American Telemedicine Association and highlights in green those states that have authorized Medicaid reimbursement for telemedicine services in a school setting. The one on the right shows states highlighted in blue where organizations are currently being supported with a telehealth network grant. Generally, for telemedicine consults done at schools, the parent's insurance is billed. And for kids without private insurance, coverage may come from Medicaid, but not universally. Only 23 states and DC allow Medicaid reimbursement for school-based telemedicine. And telemedicine has the ability for rapid assessment, treatment, and referral at all patients' convenience, and one of the most significant benefits to such a telehealth school program is the ability to provide care for non-emergent medical issues with minimal inconvenience to the patient. Another benefit is the ability to provide care for low acuity visits. One of the major goals of this grant program is to have more than 200 rural school sites connected to telehealth by the summer of 2020. Here's an example of one of our recipients' network that shows the connections between traditional hub and spoke model. You can see several spoke sites indicated with green dots receiving telehealth services in the area of chronic disease management in the states of South Dakota, Minnesota, and Iowa. And traditional hub and spoke being a brick and mortar type setting. So now I'd like to touch a little bit on Project ECHO, and part of this webinar panel, as you know, includes colleagues from the University of New Mexico whom will discuss Project ECHO in more detail and its benefits. If you have a chance to visit their website, it states that, quote, the heart of the ECHO model is its hub and spoke knowledge sharing networks led by expert teams who use multi-point video conferencing to conduct virtual clinics with community providers. In this way, primary care doctors, nurses, and other clinicians learn to provide excellent specialty care to patients in their own communities, end quote. So most of the 21 telehealth network recipients that I mentioned earlier are providing direct clinical services to rural schools via telehealth, but there are 2 that are strictly conducting Project ECHO sessions. One of those recipients is the Community Health Center Incorporated based in Middletown, Connecticut, and they develop school-based consultations for rural pediatric telehealth network, also known as SCRIPT, which combines electronic specialist consultations or e-consults with in-depth provider development sessions to empower school-based health center providers to care for their patients. Demand for these services has increased throughout the project period to date, and with clinicians expressing significant need and enthusiasm. Community Health Center Incorporated expects to see improvement in behavioral health, obesity, diabetes, and asthma for children and adolescents receiving services through participating school-based health centers across the country. And this project expects to add significant value to healthcare, including clinical telemedicine and distance learning, by demonstrating the efficacy of a virtual specialty referral and provider development system that is scalable and capable of reducing access barriers and improving care capacity across a large rural geographic area. The second recipient with their Project ECHO focus is the Kennedy Krieger Institute based in Baltimore City. Their teleeducation program employs case-based and didactic learning to address behavioral, emotional, and developmental concerns in young children. It replicates the Project ECHO model of a hub that includes a multidisciplinary team, which hosts weekly quote-unquote clinics or teleconference with spokes or 10 to 12 primary care providers or school-based health center care providers in underserved areas on the Eastern Shore and Western Maryland. The providers present de-identified cases for 45 minutes, which are discussed by all participants and summarized by the experts at the hub with recommendations for next steps. There is a 15-minute didactic presentation on a topic related to the cases presented or requested by the providers, and through their ECHO model, they are increasing primary pediatric and school-based health providers' capacity to identify behavioral, emotional, and development disorders, identify the comorbid conditions that frequently confound such disorders, manage medication, therapies, and referrals for children with these disorders, among many other benefits. One of OAT's premier resources is the Telehealth Resource Centers, and there are 12 regional TRCs and 2 national TRCs. The regional telehealth resource centers facilitate grant activities at the local level and ensure that resources are geographically distributed. They also provide training and support, disseminate information and research findings, promote effective collaboration, and foster the use of telehealth technologies to provide healthcare information and education for healthcare providers who serve rural and medically underserved areas and populations. The 2 national telehealth resource centers focus specifically on telehealth policy and technology. They share expertise through individual consultations, training webinars, conference presentations, and a significant web presence. I'd like to quickly plug that one of our national telehealth resource centers, known as the Center for Connected Health Policy, along with one of our regional telehealth resource centers, known as the Great Plains TRC, will be hosting a free webinar tomorrow from 2 to 3 p.m. Eastern Standard Time on an examination of recent telehealth policy changes at the federal and state level. If interested, please visit the website shown on this slide for more information, and note that registration should only take a few seconds. The Telehealth Resource Center website offers a wealth of information, as I mentioned earlier, including semi-annual updates on state Medicaid policies, infographics, and other useful summary reports on the benefits of telehealth utilization. Finally, the Federal Office of Rural Health Policy, where my division is housed, sends out weekly updates on these categories, including latest grant opportunity announcements. If interested, please email my colleague, Ms. Michelle Daniels, at the email address shown. Thank you again for attending, and I'll turn it over to Michelle.
All right. Thank you so much, Carlos, for sharing the work that is taking place here at HRSA and with the Federal Office of Rural Health Policy. Next, we are going to hear from Dr. Silverblatt and Dr. Roper from my home state of New Mexico. Dr. Silverblatt is a professor of psychiatry and family and community medicine at the University of New Mexico Health Science Center, where she is also executive director for behavioral health for the Office of Community Health. For many years, she has been the director of the nationally award-winning Rural Psychiatry Residency Program, which she created and developed. In January 2012, she became the director of the AHEC program for New Mexico. Dr. Roper is a clinician educator, associate professor, and the clinical director of the Project ECHO Interprofessional Primary Care AHEC Tele-ECHO Clinic at the University of New Mexico. He has been in clinical practice for more than 20 years, primarily in rural, frontier, and urban underserved populations ranging from Georgia, Alaska, Oregon, and Arizona, including along the U.S.-Mexico border. Dr. Silverblatt and Dr. Roper, the line is yours.
Well, thank you. Thank you very much. What we would like to do is kind of tag team and show in a kind of concrete way how we were able to create a broadened way of looking at the possibilities for the ECHO program, specifically in training. And we'd like to show you the value of partnerships in actually actualizing what the ECHO clinic can do. And I'm glad to hear that you're from New Mexico, Michelle. It's always great to hear another person from the land of enchantment. So this is how Dan Roper and I met. We received the New Mexico AHEC grant several years ago, which had as its focus the development of the AHEC Scholar Program. The charge was to create a cohort of health profession students across disciplines who would become experts in areas that are not often taught in health professions training. And those areas include social determinants of health, looking at integrating behavioral health and primary care, looking at cultural humility and attunement across the board, looking at best practices in primary care, and looking at ways of training a cohort of interprofessional students who would really understand the value of interprofessional training and work together so that they could transform the care within primary care in New Mexico. part of the requirements of the program include the need to develop a 40-hour didactic program a year for this 2-year program, coupled with a 40-hour clinical team-based training opportunity for all of the students. The question that we asked was, of course, how are we going to do this? And what we wanted to do was create a meaningful joint didactic program that would be accessible to students across interprofessional disciplines, including medicine, graduate nursing, undergraduate nursing, pharmacy, OT, PT, other rehabilitative services, physician's assistants, et cetera, across the board, how to create an opportunity that would be meaningful as opposed to a series of lectures that just allowed people to check boxes. We needed to also look at ways of creating a statewide team that would allow for the students who would have 2 years together to see themselves as leaders in the state of New Mexico in developing practice transformation in primary care using these focus areas as kind of touchstones. We also needed to make it easy and make it workable. So we first went to the ECHO office ourselves to see if we could set up our own clinic using the ECHO model because the outreach has been so successful. After talking with other potential partners, including the Office for Interprofessional Education, it became clear that we already had a very sophisticated primary care tele-ECHO clinic that was open to other professions, other health profession students in theory, but was primarily being used by graduate nurse practitioner students. Because this clinic that was founded by my colleague and partner, Van Roper, who will be on the line next, because this clinic had a longstanding interest in becoming interprofessional, we were able to develop this partnership with the AHEC Scholars Program and added the Office for Interprofessional Education to our mix. I'm now going to turn you over to Dr. Roper, who's going to talk about what the primary care AHEC tele-ECHO clinic really is. I hope. Let's see. Ben, are you on the line here? I don't see. I don't see. Van, are you on the line?
Yes.
Ben? Oh, good. Okay. Take it away.
Okay. So can I be heard all right?
Yes, I hear you. Yes.
Okay, good. All right. So what we're going to do today is we're going to talk a little bit more about the primary care AHEC tele-ECHO clinic. Many of you probably are already familiar with Project ECHO and how this operates. So we'll talk through some of the basics of that so that we're able to have an understanding of what it is that we're doing. All right, next slide. All right, so as many of you again already know, Project ECHO was launched back in 2003. Dr. Sanjeev Arora was the one who did this. He created this under the pretense of trying to get more specialized care into the rural areas of New Mexico. He was the state's only hepatologist, and hepatitis C was rampant at the time, and we discovered that if we could put together an audiovisual program to help train providers out in the rural areas to treat patients with hepatitis C at their home clinic, that saved the time and costs of transporting people back and forth across our state. Our state is the 5th largest state physically in the United States, and we have about a little over 2 million people, most of which are in our population centers of Santa Fe, Albuquerque, and Las Cruces. So as you start to look at the map and see how sparse things are, it was quite expensive to send people back and forth across the state, and it was averaging at the time about $600 round trip to do that. So by developing the ECHO project and creating a virtual hub here at the University of New Mexico, we were able to train healthcare providers who were tuning in remotely from around the state on how to better manage their hepatitis C patients there in their own home clinic. As a result of that, it is now expanded into a global project that is looking to amplify the capacity of being able to provide the best practice care for underserved people all over the world. Next slide. All right, so the 4 primary principles of the ECHO model has to do with using technology to leverage scarce resources, and a lot of the areas that we have throughout the United States, particularly in rural care, resources are very, very limited. So the technology is a fairly inexpensive way, comparatively speaking, rather than taking providers and shipping them around the state to go and see people. We can instead do this virtually. By being able to share our best practices, this is not only what comes out of the literature, but also from the experience of our rural providers to give them advice on how to deal with certain issues in their community that may be somewhat unique. We're able to reduce disparities as a result of that. The model is one that runs on case-based learning. It's a problem-based learning model that was innovated here at the University of New Mexico in the late 70s and then was leveraged to begin using the case-based learning on a virtual model. Basically what this does is that we're able to share cases that participants share with the hub community and be able to give a consult virtually to discuss various different aspects of care, all of which might involve things other than just medication, but perhaps particular therapies, different social determinants that need to be addressed. And all of this is done through a web-based database which monitors the outcomes so that we're able to keep a track of what it is that we're doing and what it is that we are needing to improve on. Next slide. So here's a graphic that sort of shows the hub and spoke model of this. It's sometimes, I think, one of the confusing things about trying to describe to people who haven't seen an ECHO model exactly what it is. You have a center hub where you have specialists, oftentimes academic based in the case of what we do here at the University of New Mexico. So you have expert clinicians, faculty, researchers from multiple disciplines who in turn will listen to and share knowledge and experiences on cases that are presented by the spokes, which are the outlying areas. Sometimes we'll have people who will log in and it'll be a clinic with a number of different clinicians there. Other times it might be a single clinician who logs in, and we then share not only with the hub and our comments back and forth about it, but also with other people within the network that other clinicians are able to provide impact and advice and support for our other clinicians with these particular cases. Next slide, please. The structure that we have within our clinic is a little bit different. We're strictly, at this particular time, focused on students. So students participate in our clinic as a requirement for their clinical coursework. They bring in cases that are from their clinical practice. Oftentimes their preceptors will join us. And initially this clinic, as Dr. Silverblatt was mentioning earlier, was intended for nurse practitioner students. We've since then expanded that, and this is part of what we'll review in the next couple of slides here. But right now what we have is we have a hub that has the directors at UNM as well as core faculty. We have clinical administration support there, so these are people who are keeping track of the people who are participating, making sure that the clinic operates smoothly. We have experts in a variety of different fields that are there, as well as consultants. And then oftentimes we have students, faculty, and clinicians who will join us in person in our studio so that they're able to participate live in what's going on. The other spokes, or other sub-hubs as we're calling them right now that we have, are the other 3 regional centers for the state's AHEC Scholars Program. So we have a group in Silver City, a group in Las Cruces, and another one in Las Vegas. And these particular centers have the regional directors, the faculty, the students, any clinicians and experts and consultants that would like to join them from there. And then the individual spokes that we have are generally clinicians and or students. Sometimes they're in clinic, sometimes there's a few of them in the clinic and they join collectively at one of the spokes. Other times they might even be backed up to the local Starbucks where they can get a Wi-Fi and are able to participate there in the parking lot. Next question or slide. Our vision and goals that we have here for this particular teleecho clinic is to disseminate our best practice care to all of our primary care providers so that they are better prepared to take care of their patients. One of the unique things about our clinic is that we do primary care and it's not disease specific like so many of the other echo clinics tend to be. There are some other echo hubs out there beginning to work on this, but we've been doing this for a few years now and are currently in our 4th revision of everything from rubrics for participation to case presentation forms and other items that are necessary for moving through it and refining it. Our intent is to increase the knowledge with self-efficacy through education and mentorship. We're also looking at modeling the interprofessional interactions between ourselves and students as well as other healthcare science clinicians. We intend to improve utilization and access to healthcare resources in these clinicians' communities. We often find that students, as much as 20 to 30% of them, are coming back after graduation and participating in the clinic as a professional clinician, and we also intended to model and develop this interprofessional collaboration in the patient healthcare environment. One of the difficulties we sometimes see with our students when they go out into the field with this interprofessional training is I have a lot of uphill that I need to work with here in the clinic that I'm currently in order to promote interprofessional education and collaboration. What can I do to move ahead with this? And so then we're able to also model to them ways that they can try to improve interprofessional collaboration in their own clinics. Next slide, please. Our vision and goals that we currently have at this time are to try to incorporate the AHEC Scholar focus topics into each one of our discussions. The list of them here includes social determinants, integrating primary care and behavioral health, cultural attunement, interprofessional education, primary care practice transformation, clinical focus on opioid use and pain management, as well as any local urgent issues that might come up that we need to discuss. We create a virtual model for this team-based interprofessional transformational and primary care clinical environment, and then prepare these learners to do the same thing in their own clinical training as learners in an actual practice once they graduate. Next slide. The software we use, for those of you that are not familiar with it, is Zoom software for participants. It's free to do that. They also have some limited accounts that you can gain access to for free that oftentimes limit the number of people who are participating as well as the length of time that you can run it. We've been using this software since inception and it seems to be working quite well. You can participate without a web camera. Oftentimes people are using smartphones, iPads, and what have you to do this participating. They also have the option of just calling in strictly by phone so that we just have a vocal interaction with the participants. The numbers that we provide for them in order to keep this as a managed participant group that we're working with are by email invitation. So anytime someone requests to be a part of this, we go through and verify that they're either a student or a licensed healthcare professional, and then turn around and send them an invitation along with the link up information in our weekly announcements for this. Typically when they get the email, it's pretty simplistic where you just click on either a one-click for most smart devices that will link you up into the session. You'll have to enter in a password that we have. It even scans your device to see whether or not the software is there, and it will download it. And then once you get into it, you put in this unique meeting password. And this information is in each one of our email invites so that people will have easy access to it. We even do things like try to send out a reminder immediately before clinic so people don't have to go dig back through their emails to try to find the initial invite that usually goes out earlier in the week. Next slide.
Let me
All right.
thank you, Dan, for really explaining very well the ECHO model and how we were able to integrate the AHEC Scholars Program into the existing primary care ECHO clinic that you had structured. And we hope that you also got a sense of some of the nuts and bolts of how to get the system going. I just wanted to spend 1 minute talking about other telehealth training possibilities that are very important, I think, and that we have found very important in a rural state like New Mexico. It's not necessary to use the ECHO model to do this, but I think it's important in terms of, again, in terms of partnerships and success. In the behavioral health field, it has been very important to try to figure out more extensive ways to provide supervision. Many behavioral health providers in isolated rural or frontier communities do not have access to supervision, and that stops them from getting advanced degrees, from getting advanced certification, or from being able to bill for their services. So telehealth using protected technology, including Zoom or other technologies, has been crucially important for us in our ability to increase the number of rural providers who become independently licensed. We've been able to get permission, for example, from the Social Work Association to provide telehealth virtual supervision. This has been crucial in enhancing the number of social workers in the state. We've also gotten permission to provide, from them, to provide individual as well as group supervision. And then one other added statement is that in the rural residency program that we've instituted over the last 20 years, where we did not use telehealth initially, as our telehealth program became more robust, we were able to successfully integrate telehealth supervision in terms of supervising residents in how to use telehealth. So it's I guess the meta level of academic supervision is supervising a resident who's doing telehealth, not only in his clinical or her clinical expertise, but also in the use of the technology. We also are able to use telehealth just to provide more traditional supervision for our residents who are based around the state. Okay, next slide. Thank you, and there's a beautiful New Mexico rainbow. We are the New Mexico Rainbow Coalition here in our AHEC Scholars Program, and we want to thank you very much for joining us today, and we welcome your questions.
All right, so thank you very much for the great presentation. I see that you all are answering some questions in the chat, and we will hold on some of the, taking some of the ones on the call, and we'll move on to our next presentation. Next, we will hear from Dr. Sharma and Dr. Greenwald. Dr. Sharma is the chairman for the Department of Emergency Medicine and the Emergency Physician-in-Chief at New York Presbyterian Weill Cornell Medicine. Dr. Sharma has devised and led several innovative initiatives and educational programs which have significantly improved patient and clinician experience, core quality measures, and overall operational efficiency. He is a national leader in the fields of emergency medicine, healthcare operations, telemedicine, and virtual healthcare. Dr. Greenwald is the Emergency Medicine Telehealth Service Co-Director and Director of Emergency Medicine Telehealth Quality Assurance at New York Presbyterian Weill Cornell Medicine. Dr. Greenwald is a board-certified emergency medicine physician, a graduate of SUNY Downstate Health Science Center, Brooklyn, and completed his residency at the Albert Einstein College of Medicine, Jacobi Medical Center. Dr. Sharma and Dr. Greenwald, please proceed with your presentation.
Great. Thank you very much. This is Rahul Sharma. So over the next several minutes, I want to give a background of what we've done here at New York Presbyterian and Weill Cornell Medicine, and then specifically talk more about the training and education program that we've implemented here. Next slide, please. So just some background on our New York Presbyterian services that we offer. I'm not going to go into detail on all these services, but we actually offer telemedicine visits within the ED, which is known as ED Express Care. That's what we initially started with. We also offer a virtual urgent care service where patients could speak to one of our physicians from home or the office. We also have put about 8 kiosks across New York City in various pharmacies, Walgreens pharmacies, so patients could do telemedicine visits from there. We also have a congestive heart failure follow-up program where we do telemedicine from the home with use of paramedics. And then also we've had telemedicine visits for medical screening exams. So when you come into the emergency department, one of the common complaints is that you wait a long time to see a provider. What we've done is we've actually put telemedicine right in the front so patients could actually be seen, orders could be placed to initiate the care in the emergency department. Next slide. So this just shows a timeline of where we started in 2016. In 2016, we started with our ED Express Care program, and then we rolled out telemedicine visits by board-certified emergency physicians to patients that were at home or at the office. In 2017, we then expanded to pediatrics, included pediatrics as part of our on-demand virtual urgent care program. In 2017, we also then opened up to visits to employees of New York Presbyterian. We also partnered with ZocDoc as well as different pharmacies, as well as Walgreens and Duane Reade. And then we also started doing some telemedicine visits with our paramedics. And then in 2018, we then started doing telemedicine visits for our medical screening exams. We then also started doing med reconciliation of patients that start off in the ED to really help our inpatient colleagues. And then recently we launched a virtual patient observation, a telesitter program to help reduce falls in the emergency department. And in 2019, we have several other programs planned. So as you can see, we started off with one program and now have expanded to several programs. Next slide. So in 2018, we finished NYP as an enterprise, did over 100,000 telemedicine visits. Actually, the updated numbers are greater than 120,000. And through our emergency department at New York Presbyterian Weill Cornell, we did about, the number is closer to 40,000 visits. And that encompasses our medical screening exam, pharmacy med reconciliation, our express care, our virtual urgent care, as well as a telesitter. Next slide. So why is this important? As we are all well aware, the United States, healthcare costs are a significant portion of our GDP versus other industrialized nations. And many healthcare systems, including New York Presbyterian, are really trying to improve access, improve outcomes, and reduce costs. And one way that many healthcare systems are doing this is by the use of telemedicine. Here at New York Presbyterian, we talk about standardizing, virtualizing, and regionalizing, and all of that can't happen unless you really get all the key stakeholders engaged. Now, next slide. So as we expanded our telemedicine services, one thing that we learned right away was that you can't continue to expand our programs unless you're making sure that our clinicians are adequately trained and our learners. So who are our telehealth learners? It's not just about physicians. It's about everybody and as a part of the healthcare team. It's about the pharmacists. It's about our nurses. It's about our NPs. It's about our PAs. It's about our medical students and our residents, anyone that's involved in providing healthcare. The American Medical Association has actually taken a stance, and they encourage telemedicine training for all medical students and residents. While they do encourage that, the fact is that many medical schools and many residency programs don't have telemedicine as part of their curriculum. We talk a lot about bedside manner, but now it's a lot about webside manner. So I'm going to hand off to Dr. Greenwald, who's going to tell you a little more about what we've done to train our clinicians and what we plan to do in the future. Peter?
Yeah, thank you, Rahul. As Dr. Sharma said, we feel it's essential that all providers engaging in telehealth in our institution are adequately trained in order to be able to put their best foot forward when they're providing this kind of care. And to that end, we've developed a curriculum that has 3 basic parts. We teach the basic mechanics of telemedicine. We teach our providers about web etiquette, what people refer to as bedside manner. And more we're beginning to teach our providers what we're learning about remote patient examination skills when we're on real-time video. We've delivered versions of this curriculum in a variety of different venues. Most importantly, this is now a component of our third-year medical student primary care clerkship at Weill Cornell. So starting this year, every resident that will graduate from Weill Cornell will have been exposed to this telemedicine curriculum. We also have a more in-depth elective that we provide for fourth-year medical students. We have an elective we teach our own residents in emergency medicine, telemedicine. And of course, we teach our own providers, senior providers, junior providers who are entering into telemedicine. We've done this both within our department and for other departments within the enterprise. And we just held the first of what we hope to be an ongoing conference where we teach virtual healthcare skills. The components of the basics are ensuring that documentation is adequate, that all visits that are by telemedicine clearly reflect that they're done by telemedicine, and also provide some clues to the context of the visit. I think it stands to reason that the type of care that's provided for someone who's in a remote location with no resources might be different than the care that's provided to someone who is 2 blocks from the hospital, just choosing to call from home. So we teach our providers to explain the context of their visit as they're writing. Telemedicine billing is obviously a rapidly evolving landscape, and we make sure that all the folks we run through our courses work closely with their billers to make sure that we are documenting what the billers need to do their job. We also make sure that all our providers are aware of some of the nuances of licensing and credentialing. Providers need to know the details of telemed regulation in the states where they're providing care. They also need to know that they need to be licensed in the state where the patient is. And this is something we're realizing is not intuitive to our providers, and by the way, not intuitive to our patients either. We also ensure that all our providers know that they can't just pick up any old program, that they need to be performing telehealth visits through platforms that are vetted by the institution and that are HIPAA secure, and that they need to be performing these visits in a way that encourages the maintenance of privacy. Next slide. I think I skipped saying next slide, so we should now be on a slide that says bedside to webside.
Yes.
Bedside manner. This is important therapeutically, right? What we bring to the bedside is engagement, openness, empathy, a feeling of focus where we're directly connected to patients. This is done with a variety of verbal and nonverbal communication skills. Some of these techniques that we use at the bedside also work well over the camera, but some don't. I mean, you can take the obvious example of you can't put your hand on someone's shoulder. But the details, like making eye contact, like slowing down your speech cadence, like announcing to patients when you're doing things like taking notes or working in an adjacent computer that they can't see. These end up being very important in fostering the same sense of connection that Bedside Manner has, only over this video visit medium. Next slide. So we do this training, with experiential learning and simulation. We record interactions where our providers have a visit with a standardized patient over video. Our actors are in a different place where our physicians are. We record these videos and give our providers an opportunity to see what works and what doesn't work over the video. We do that with guided debriefs in small group settings where collectively our learners can see what works and what doesn't. And as we're delivering those small group debriefs, we work in things about the basics, about the legal requirements for doing telehealth visits, the other essential things we think our providers need to know. Next slide. So these are stills taken during our simulation sessions. And you can see the before and after. This provider delivered his entire discussion looking at what he thought was the patient on his screen, which of course bore no resemblance to where the camera was. And you can get a sense, just looking at these two simple stills, how different in interaction the one on the left from the one on the right was. Maybe most importantly, our providers really like these sessions. They all say they don't want to see themselves on video, but then they are immediately engrossed when we start running the clips, and we really gather people's attention. Our third-year medical students enjoy it. Our 50-plus crowd senior providers enjoy it. So I'm going to end there. Thank you.
All right, thank you both for that wonderful presentation, and thank you to all our presenters. I'll turn it over to Carl.
Excellent. Thank you all once again to our presenters. And what I'd like to do is, for those of you that are still in attendance, we are going to switch over. There's some poll questions we'd like for you all to answer, but now is kind of the official start of our Q&A for all of our presenters. So what we're going to do is we're going to work through some of the questions we've received over the chat pod, but I'd also ask that the operator please go over the instructions for those on the phone, how they can queue up to ask the question.
Thank you. We will now begin the question and answer session. If you'd like to ask a question, please press *1 and record your name clearly.
Hi, this is Michelle as a moderator. While we're waiting for those to pick up, to get those in queue, I did find some questions from the chat box that we wanted to see if maybe some folks have answers to. One was, is there an evidence base that a Project ECHO has a measurable impact on improved patient outcomes or on improving access of patients to services that are satisfactory and effective? I think there were a couple of those questions. I'll turn it over to the speakers. Dr. Silverblatt, or?
Well, you know, I think I don't know the answer to their latest evaluations. I don't know, Van, if you have more data with ECHO in terms of that aspect of what they do. I can't say that I know the exact answer, but I can try to get information from the ECHO program. I know they have a very robust evaluation system in place, and that's just what they're trying to figure out.
Yeah, that's pretty much my same impression of what's going on with that as well, since most of what we're doing is focused on students and trying to develop the interprofessional aspect of clinic. I've not been deep into that research on that side of it, but would certainly be something that we could look into and provide that for the participants.
Okay, thank you. Are there any questions on the phone?
No questions at this time.
Okay, let me look at some other questions I know that we had and that I had was, do you have any, for Dr. Sharma, where can one find or access any best practice resources for telehealth training of providers?
Peter, you want to take that?
I think we're going to have to get busy on writing some of what we're doing down and getting it out in the peer-reviewed literature. But I believe my contact information is available through this conference, and I would be happy to offline answer any questions or give you a more detailed version of what we're actually delivering to the students.
Yeah, this is Rahul Sharma. The one thing that I want to emphasize is that, while our telemedicine learners are a vast group of people, the way we've designed our curriculum, it doesn't matter who you are, whatever role you have, everyone goes through the same training in terms of simulation, the basics, as well as suggestions, as well as the training program. It's not any different for a nurse versus a doctor. This is a new field. There isn't a lot really out there on core competencies for telemedicine, what is required in terms of a skill set. One thing that I do want to just emphasize, it's not just about FaceTime. It's not the same as, just going in front of your iPhone and start chatting with someone. There's actually a science behind this, and just from the last year or two of doing this, you will be surprised at how much you could actually utilize a patient to actually help in the physical exam and the actual diagnosis of certain conditions. So, as Peter said, we're publishing a lot of this data, we're getting a lot of the data, and hopefully we'll get it out in peer-reviewed literature soon.
All right, thank you very much. Any questions from the call?
No questions at this time, but as a reminder, to ask a question, please press star followed by number 1.
Carlos, for you, I did see a number of questions about people asking if there was telehealth available in a certain particular state. I wasn't sure if you would want to highlight some information for them of where to go and look for that.
Yeah, sure, Michelle. So just wanted to touch on the couple resources for folks to visit. The first one that was in the presentation I gave is the website, the telehealthresourcecenter.org. That's singular, telehealthresourcecenter.org website. And they're one of grant programs that we supported for 10 plus years. And like I said, there's 12 regional TRCs and 2 national, and they are there for HRSA recipients to access for any question on technical assistance for telehealth, or anything telehealth. So whether it's, what would be the best camera, for example, to purchase for derm consults. They have a sort of consumer reports recipient or a telehealth resource center that grades different types of technologies and equipment for folks and can make the best recommendations for your particular needs for your local community. And if one of them doesn't have the answer, even though they're highly skilled and set the benchmark for telehealth for their particular region and the states that they serve, they can certainly tap into their fellow colleagues at other regional resource centers to get that information or response for you. So they work extensively well together. So that's one resource that I highly recommend folks reach out to them for TA on anything telehealth. And the other one, of course, is the grant opportunities, which we don't have for telehealth at this time, but for the Telehealth Network Grant Program, we do intend to recompete that next year. So please feel free to reach out to me for more information on any telehealth grant opportunities that we intend to make available by next year. And of course, you can also visit the website www.grants.gov and just type in telehealth in the word search. You'll probably find one or two opportunities out now across federal departments that are available. But from our office, touch base with me next year if you're interested on any telehealth opportunities. Thank you.
Thank you,
Just,
Carlos.
Dr. Greenwald, let me tag on that, a shout out to the Northeast Telehealth Resource Center. They've been tremendously helpful to us as we've gotten our programs up and running.
Excellent. Thank you, Doctor. I'll let them know.
We do have a question on the line. Dr. Shelley, thank you. Dr. Shelley Cooper, your line is open.
Thank you. Hi, I'm calling from Kansas City, and thank you for such a great informational webinar. I've been doing telehealth on a consulting basis for the last 4 or 5 years, and I've found that one of the major barriers to acceptance of telehealth is not only the reimbursement factor, but also the compact issue of state compacts. Could you give us an update or tell us what you found in terms of the reimbursement issue and the medical compact issue? Hello?
Would one of our speakers like to take that question?
I can add to that. Thank you for your question. This is Carlos Mena again with the Office of Advancement of Telehealth, and one grant program that has worked on licensure portability or working with several states for decreasing barriers towards practicing telemedicine across state lines is the Federation of State Medical Boards with their physician compact, and I think they have about 25 states now on board in that consortium that use reciprocity to recognize license from physicians in other states so that they're able to practice in their respective states within the consortium without having to go through all the application requirements to be able to practice in a particular state that they're interested in if they hold one or more licenses. So they made great strides at the Federation of State Medical Federation of State Medical Boards. They have made great strides in the last 15 years with increasing number of states on board in that consortium. I have the contact information if that's helpful for them. The other question on reimbursement, of course, that has been the number one barrier, for lack of a better word, for many of our recipients in terms of Medicaid reimbursement at the state level. So supporting these types of demonstration projects through the school-based telehealth network grant program, for example, where there's 21 recipients in our current cohort, and about half of them are supported through Medicaid. Others are working to have some good outcome data from the work that they're doing to present to policymakers and hopefully have some adjustments made at the Medicaid state reimbursement level. So this is a work in progress, and of course, as we're trying to do in the office, is build that evidence base as well to support our recipients and the great work that's occurring in the cohort. So, but that continues to be a challenge, and I do encourage folks again to, if you're interested more in that federal and state policy level of telehealth and what's occurring with reimbursement, I do encourage folks to register for the free webinar that's being held tomorrow by our Great Plains Telehealth Resource Center from 2 to 3 for more information, where they have the policy experts to talk about that and give a nice overview.
Thank you.
If I could add just one quick thing, just to piggyback along what you were saying, Carlos, that it really, to get change in this realm, you kind of have to get to know your state representatives, at least in the Medicaid sphere. And I was not involved in the specifics, so I'm afraid I can't give you the specifics, but of how we were able to get reimbursement from our telehealth providers that would also allow for reimbursement for the site as well as for the providers, both the telehealth site and the and where the patient was. It took some work, but it did involve a state bill, and it brings up the question of how we also train in terms of policy issues to our students and peers. But it did take a political action to get the billing changed.
Thank you for that. Are there any other questions on the line?
Questions at this time?
Okay. One question that came up a couple of times in the chat, and I'm not sure, I'll put it out to everyone. Has anybody had any information about special consent, patient consent forms, telehealth consent forms for patients to be used, or how do you develop your protocols around that, and also around patient satisfaction from using the telehealth?
This is Dr. Sharma. I can comment regarding patient satisfaction, certainly. You know, when we first started our telehealth program, we weren't sure exactly how patients were going to react to it. And surprisingly, you know, contrary to what we initially thought, some of our most satisfied patients are actually our geriatric patients who end up using telemedicine, especially in the emergency department. We found that from prior surveys that our satisfaction is greater than 90th percentile in those patients. And we call every telehealth patient the next day as a follow-up. And I will tell you, just our results and our comments that we get is overwhelmingly positive. Many patients view this as convenience, high quality. Also, they don't necessarily have to travel to the emergency department for certain things. So I would say that overall patient satisfaction data has been very positive.
Thank you. Do any of our other presenters want to jump in on that question?
We have in the past developed these sorts of forms involving consent and with our risk management people, and those are given to the, and we work also with the sites involved to develop the kinds of necessary permission forms that we use.
All right, thank you. Any other questions from the line?
We have no questions on the line.
Okay. Some other questions that we did see is if the curriculum is available for distribution, Dr. Sharma and Dr. Greenwald, or if folks can go ahead and contact you all after the presentation to discuss more about the curriculum and how it was developed.
Sure.
Okay. Any other questions?
We do have another question from Dr. Shelley Cooper. Your line is open. Please unmute your phone. Your line is open.
Yes, this is Dr. Shelley Cooper at Diversity Telehealth. I was calling asking again about the school-based telehealth initiative. If someone could provide information on possible asthma management and other chronic disease management efforts using telehealth, either in the schools or possibly in FQHCs.
Yeah, sure. This is Carlos Mena again with the Office of Advanced Telehealth. Appreciate the question. And what I can do, if you can email me at cmena@hrsa.gov, that's CMENA@HRSA.gov. I can send you back the latest grantee directory that we have, which has one-page profiles on what each of our 21 recipients are doing in the school-based setting for telehealth, and specifically around asthma, for example. There's a screening going on in Michigan through telespirometry. There's also screening for oral health of kids to see if they need follow-up to have sealants or implants put in place. And then healthy weight, of course, measuring the BMI of the kids. So there's a lot of great work going on. Every project is very unique. And on the one-page profiles, there's point of contact information. There's the type of equipment that recipients are utilizing for the telehealth. There's a brief project description, as well as the counties that the recipients are serving. So I think it's a great resource, and it is available actually on the HRSA website. And if you just Google HRSA Telehealth, it would be there on that main page for our office as a publication for the grantee directory, and you'll see all the profiles across actually all of our grant programs, not just school-based telehealth. Or feel free to reach me by email, of course.
Thank you. Could you repeat that email again, please?
Yes, it's CMENA, CMENA @HRSA.gov.
Great. Thank you. Appreciate it.
Yes, ma'am.
We'll check again on any questions from the phone.
As a reminder, to ask a question, please press star followed by number 1.
While we are waiting, there was another question around, has anyone had experience with the telemedicine training modules that are offered for the board-certified telemental health providers? And if you are on mute, our presenters, please unmute. If not, I will move on.
Yes, right. Can you repeat that again? I'm not sure I can answer it, but I was just wondering. And I just want to add, before you repeat that Dr. Oprah reminded me, we are also, I don't know, about 20 miles apart, but that we do have a dental department at UNM where we have dental hygiene students, but we don't have a dental school itself. And I don't know if someone had asked this question. I'm not aware of any teledental programs, but we can find out. I mean, that doesn't mean they don't exist. And then could you repeat your question again, please? Thank you.
Yes. So the question was around experience with telemedicine training modules that are offered for the board-certified telemental health credential.
I am not sure if you're talking about specific. I'm not sure if the question is asking about specific licensing programs or about more general telehealth, mental health issues. We have a very robust training program to train providers who are involved in different aspects of mental health services. From many of them are through the Indian Health Service Center for Behavioral Health, Center of Excellence for Telebehavioral Health that we have with UNM. I don't know about training modules per se, but we do offer we offer a regular program through the Indian Health Service Center of Excellence in Telebehavioral Health offers a regular series of classes. I'm not sure they're answering the question that was asked, however, because I'm not sure how to answer that specifically.
Okay, I thought I saw the person starting to write another bit in the chat box, so we'll just give that a minute. From the phone, is there anybody on the phone that has another question?
Yes, our next question comes from Jim Beasley. Your line is open.
Thank you.
Hi, this is Jim Beasley from the Rhode Island Department of Health. I want to thank you for the presentation. I just have a quick question about how or what validated instruments that you use to measure provider self-efficacy with any of the new competencies or training modules that you are giving.
Yeah, Dr. Greenwald. We're in the process of developing and validating an instrument that measures both self-efficacy as well as independent objective verification of that efficacy. So watch this space. Maybe 10 months from now we'll have something out.
Thank you.
Our next question comes from Susan Griffin. Your line is open.
Thank you. I am actually the one who asked the question about the BCTMH credential. And to be honest, I cannot recall at this moment the name of the certification organization that issues that credential. But their training modules for telemedicine cost about $500 per provider. So if I have 10 providers that I want to train, obviously that's going to be pretty costly. So that's why I was asking if anyone had purchased those modules and had had experience to, just to how helpful they were. The content actually looks quite good, but I just wondered if anyone had any actual experience with it. That's why I was asking the question.
Great. Well, thanks for clarifying that. I appreciate that. I don't have an answer because I don't think we have purchased any of that academic support, training support. Could you tell me the name of it again? Because I'll look into it. What is the name of it again?
The credential is BC-TMH, Board Certification in Telemental Health. But honestly, I cannot remember the certifying organization. But if you just Google that credential, it'll come right up.
And who are you thinking of offering it to in your program?
In our program, it would be our behavioral health providers who were going to be participating in our telemedicine program.
And that would be across disciplines, right? Nurse practitioners, PAs, psychiatrists, psychologists,
yes.
social workers? Yes.
Yes,
okay.
Absolutely.
Okay, great. Thank you. I'll see what I can learn and find out. Thank you.
Thank you.
Hi, this is Michelle again. Is there any other questions? I think we have a couple of a time for maybe one or two more questions from the phone.
At this time, we have no further questions.
Okay. Scrolling through some of the questions, trying to pick them up. I think there were a couple of questions around how do the participating providers they tend to have certain time that is protected from their institution, so they're able to use clinical time or other training activities. How have you all found the providers having the time to take away from their clinical services, their teaching, to be able to do some of the telehealth?
This is Rahul Sharma. So we have about 18 of our faculty that are part of our telemedicine program, and it's embedded in their clinical requirements per year. And I will tell you, just speaking to faculty, it has really helped with morale, burnout, and overall job satisfaction. While being an ER physician, working in an ED that's very crowded, busy at times, could be challenging, and especially for our senior faculty who've been out 10, 20 years, we found that they really value the opportunity to provide telemedicine care to our patients. So we've gotten great feedback. It is part of their clinical requirements, so they don't have to work more. It's just a different type of work that they're doing. Peter, if you want to comment, you can.
Specifically with the education that's required, we consider that a prerequisite to doing telemedicine work, and that's not only for the 17, 18 of our faculty of almost 100 who are doing this. That's also for our NPs and PAs who are performing this kind of work. Whether the enterprise goes forward and requires the training we're offering within our own department and for select other departments that request it is yet to be determined, although the discussion's ongoing about that.
I would just like to add that in terms of enlisting community-based faculty, it becomes more challenging for them to often get away to participate in telehealth or echo clinics. And what we have tried to do is try to meet at times that are most convenient for the community-based faculty. So our clinic meets at lunchtime, for example. And that seems to work fairly well for students as well as community faculty. But that's always a dilemma, frankly, in trying to engage community-based faculty in telehealth training and participation.
Thank you very much for all of that. So I think that is all the time that we have today for this webinar. I just wanted to thank you all so much, to the presenters today and to all of the participants. I'm sure I can speak for the audience that there was some really great content that was covered in the presentations. All of the presentations are available for download. I believe we've mentioned that before. Please continue to let HRSA know how we can support you in all of your efforts, and thank you again to all involved with the presentation. And if there is any...
Thank you.
Go ahead.
Thank you.
Thank you for your participation in today's conference. Please disconnect at this time.